Hello, this is Antiplatelet Anticoagulant, and this lecture will cover antiplatelet and anticoagulant drug therapy. The goals of the lecture today are to explain the pharmacology of antiplatelet and anticoagulant drug therapy agents, to describe monitoring parameters and adverse effects of antiplatelet and anticoagulant drug therapy agents, and also to identify appropriate antithrombotic therapy in atrial fibrillation and venous thromboembolism. So there are two functional units of blood coagulation: platelets, which start the clotting process, and fibrin, which is a portion of the blood clotting cascade that forms the clot complex. Now there are many steps to forming a clot, but to form a good clot, the three primary essential steps are to form prothrombin activator or factor Xa. So platelet activation or tissue damage initiates the process of forming factor Xa, which we'll review in the next couple slides. And we need prothrombin activator or factor Xa because it converts prothrombin to thrombin. And thrombin is important because it transforms fibrinogen to fibrin, which is the essential ingredient needed to reinforce the clot for long-term effectiveness. To break thrombogenesis down even further, starting at the top of the slide with endothelial injury, whenever there is a defect in the blood wall vessel, platelets adhere to exposed collagen of the damaged endothelium and become activated. Activated platelets release adenosine diphosphate, or ADP, serotonin, or 5-HT, and thromboxane A2, or TXA2. These substances then activate additional platelets, and platelets begin to aggregate. The aggregated platelets start to lose their individual membranes, they release their contents, and they form a gelatinous mass. And this mass, or platelet plug, quickly stops the bleeding, but it needs fibrin reinforcement to make an effective clot. So the aggregated platelets activate the clotting factors of the blood coagulation cascade, which leads to the formation of fibrin. Now, of course, we have to have a negative feedback system incorporated into this process, and that's represented here by prostacyclin, or PGI2. PGI2 is synthesized within the vessel walls and inhibits thrombogenesis. We'll see later on in the lecture how antiplatelet medications interfere with this process of platelet activation and aggregation that's shown here. Now this is a somewhat simplified figure of the blood coagulation cascade. The clotting factors are represented by the Roman numerals, and at each step, a clotting factor undergoes a conversion to an active clotting factor. So the Roman numerals with an A after them are the active clotting factors. So looking at the top of the slide, there's factor 7, which is inactive, and factor 7A is the active factor 7. So these activated factors then catalyze the next step in the cascade, and it goes on, ultimately resulting in the formation of fibrin. So this cascade is important when we talk about the mechanism of action of anticoagulant medications and how they interfere with the process shown here. Antiplatelet therapy is used to decrease platelet adhesion and aggregation, and there's a variety of uses for antiplatelet therapy, but the ones that you'll most see in primary care are for the prevention of atherosclerotic events such as stroke, TIA, MI, and vascular disease.
The antiplatelet medications that we'll discuss in this lecture include aspirin, dipyridamole plus aspirin, otherwise known as Agrinox, clopidogrel or Plavix, prasugrel or Effient, and ticagrelor, which is Brilinta.
Aspirin inhibits platelet aggregation by inhibiting the synthesis of the prostaglandin thromboxane A2, which, as we know from a previous slide, causes platelets to activate and aggregate. Aspirin inhibits the synthesis of thromboxane A2 from arachidonic acid by irreversibly acetylating the enzyme cyclooxygenase. So aspirin is absorbed in the stomach and intestines, and conventional aspirin has antiplatelet effects in about an hour. Enteric-coated aspirin takes a little bit longer, 3 to 4 hours, and that's why it's recommended that if you need rapid antiplatelet activity because someone is having an MI, for instance, and you only have enteric-coated aspirin available, it's recommended that the patient chew the aspirin to destroy the enteric coating so that you can get more rapid antiplatelet effects. So the half-life of aspirin is very short, 15 to 20 minutes, but the antiplatelet effect is prolonged. And this goes back to the irreversible inactivation that I talked about in the last slide. So the platelet inhibitory effect lasts for the lifespan of the platelet because aspirin irreversibly inactivates platelet enzyme cyclooxygenase. So platelets cannot manufacture a new enzyme in their 10-day lifespan. So what this means is that since about 10% of circulating platelets are replaced every 24 hours, 5 to 6 days after taking aspirin, about 50% of the platelets are functioning normally. So just to note, NSAIDs like ibuprofen or naproxen, they also inhibit cyclooxygenase, but their action is reversible. So therefore they have a shorter duration of inhibitory effect. So we know that we dose aspirin once a day when we're giving it as an antiplatelet therapy because it knocks out thromboxane A2 production for the life of the platelet. But how do we know what dose to use? Do we use 81 milligrams? Do we use 325 milligrams? Well, the right dose varies for different vascular disorders. So we do know from studies that aspirin lacks a dose-response relationship, meaning that increasing the dose of aspirin used in a specific disorder doesn't necessarily improve our outcomes. We also know that unwanted side effects of aspirin are dose-dependent. So it's recommended that we use the lowest dose shown to be effective in a particular indication. This slide has a summary table of these doses, which is from the 2012 CHEST guidelines on antithrombotic and thrombolytic therapy from the section on antiplatelet drugs. So this is the most recent version of the CHEST guidelines that covers antiplatelet drugs, and you can review these doses at your leisure. So toxicity and monitoring, bleeding is going to be a common theme in this lecture, the adverse reaction of bleeding and monitoring for bleeding. The risk of bleeding increases with an increased dose of aspirin, and we also know that bleeding risk increases when we're using other anticoagulants or other antiplatelet medications in combination with aspirin. So you also don't want to use aspirin in active bleeding, so patients with peptic ulcer disease or intracranial hemorrhage, and you want to monitor for signs and symptoms of bleeding with aspirin use. Stomach upset is also a potential side effect. Aspirin has a strong affinity for cyclooxygenase and it inhibits it wherever it's found. And cyclooxygenase is also found in the intestinal mucosa. So we also decrease the protection of the stomach lining from acid when we inhibit cyclooxygenase. Now the effect is dose related, so lower doses used for antiplatelet indications like we're talking about versus using aspirin for an analgesic. In your patients who are just taking your once a day aspirin for cardioprotection, stomach upset probably won't be as much of a problem. I also wanted to talk about drug interactions with NSAIDs. It's important to note that using NSAIDs and aspirin may limit the effects of aspirin's cardioprotection. And this is because medications like ibuprofen, naproxen can interfere with the antiplatelet effect, potentially rendering aspirin less effective. What's really happening here, as I said in the previous slide, is that NSAIDs also acetylate the enzyme cyclooxygenase. So there's some competition for those receptor sites, and ibuprofen can interfere with the aspirin binding. So it's really important to counsel your patients to time your doses of NSAIDs. If they take NSAIDs for pain on a regular basis and they're also taking an aspirin for cardioprotection, they should take their NSAIDs 30 minutes after or 8 hours before their aspirin to avoid this interaction. Moving on to dipyridamole. Dipyridamole works by inhibiting cyclic nucleotide phosphodiesterase, which is an enzyme that degrades cyclic AMP within the platelet. So by inhibiting this enzyme, you get cyclic AMP accumulation, which leads to platelet inhibition. Dipyridamole also stimulates prostacyclin synthesis, which that I talked about earlier. Prostacyclin is a component of our negative feedback system. And then dipyridamole also has vasodilatation properties. Dipyridamole comes as a modified release formulation that's combined with low-dose aspirin, which improves the bioavailability of the drug. So the capsule has 200 milligrams of dipyridamole in it and 25 milligrams of aspirin, and it's taken twice a day, and it's used in the secondary prevention of TIA and stroke. Headache is the most common side effect seen with dipyridamole, and it's possibly due to the vasodilatation effects. Of course, we need to monitor for signs and symptoms of bleeding with this medication, and we should note that the capsule needs to be swallowed whole because it's an extended release formulation, so it can't be crushed or broken. Other antiplatelet agents we'll discuss are clopidogrel, ticlopidine, prasugrel, and ticagrelor. So their antiplatelet effect comes from the inhibition of the ADP receptor on the platelet. They differ from aspirin in that they have no effect on prostaglandins, so we don't have to worry about the GI mucosa. Now these agents also irreversibly bind to the platelet for the life of the platelet, with the exception of ticagrelor, whose interaction with the ADP receptor on the platelet is reversible, which does impact its duration of effects, and we'll talk about this later. Clopidogrel is dosed at 75 milligrams a day. It's used at higher doses in acute coronary syndrome. Its antiplatelet effect after a loading dose is about 2 hours, and then if we use conventional dosing, it's usually on day 2 of therapy. There is a cumulative inhibition of platelet function similar to aspirin after repeated dosing. So after stopping clopidogrel, platelet function returns to normal after about 7 days. Clopidogrel undergoes extensive hepatic metabolization through the CYP1A2 and 3A4 pathways. Therefore, macrolide antibiotics, atorvastatin, and simvastatin may attenuate the effects of clopidogrel. The risk of bleeding is increased when it's used with other anticoagulants or other antiplatelet agents, although it's important to note that concurrent use of Plavix and aspirin is often seen in practice. Of course, we need to monitor for bleeding, do not use inactive bleeding, and there have been cases of TTP which have been reported. It usually occurs in the first 2 weeks of therapy. These next two agents aren't prescribed much in primary care, but I want you to be aware of them and their potential side effects and toxicities. Prasugrel has a higher, more rapid and consistent platelet inhibition than clopidogrel and potentially more bleeding risk. It's contraindicated in active bleeding and in patients with a history of stroke or TIA, so you won't be using this agent for secondary prevention of stroke like you may use aspirin or Agrinox or clopidogrel. There are some additional risk factors for bleeding, such as patients that are older, greater than 75, weigh less than 60 kilograms, or are on other medications that increase bleeding risk. The maintenance dose is 10 milligrams per day, and other infrequent EDRs are listed here. Ticagrelor is also not indicated for stroke prophylaxis. It does seem to have better efficacy than clopidogrel with similar risk of bleeding in most cases. It has a quicker onset of action, but it has a shorter duration of action because of the reversible platelet binding. So this is the outlier in that it's not irreversible platelet binding, but it exhibits reversible platelet binding, which causes the shorter duration of action. Its maintenance dose is 90 milligrams twice a day. And I think the most important thing here to note is that the maximum concurrent aspirin dose that can be given with ticagrelor is 100 milligrams a day. So aspirin doses greater than 100 milligrams are associated with decreased effectiveness of ticagrelor. It's also contraindicated in active bleeding and also with strong CYP3A4 inhibitors and inducers. And then also interestingly, some patients experience dyspnea in the first week. Now we'll move on to the anticoagulant medications. We'll be discussing low molecular weight heparins, and although there are others, the most commonly used ones are enoxaparin and dalteparin. We'll talk about our factor Xa inhibitor fondaparinux, which has a similar mechanism of action to low molecular weight heparins, but it's a completely synthetic compound. We also have warfarin, which is our vitamin K antagonist, and then we have direct oral anticoagulants, or DOACs, dabigatran, rivaroxaban, apixaban, and edoxaban. Low molecular weight heparins are called this because they are about 1/3 the molecular weight of unfractionated heparin. These smaller fragments have a reduced ability to inactivate thrombin, but they inactivate factor Xa almost as well as larger molecules. Therefore, they have a more predictable dose-response relationship than unfractionated heparin. They're used in the prevention and treatment of VTE, acute coronary syndrome, AMI, and then also as bridge therapy to anticoagulate patients during interruptions of our vitamin K antagonist, or warfarin. This is our slide of the coagulation cascade that I talked about earlier. I've drawn a box around factor Xa to give you an idea of where it is in the cascade. Low molecular weight heparins are given by subcutaneous injection. Their peak anti-factor Xa activity occurs at about 3 to 5 hours, and it has a more predictable dose response than unfractionated heparin. Its half-life is about 3 to 6 hours, which is longer than unfractionated heparin and not dose dependent. So based on this pharmacokinetic information, it's reasonable to use low molecular weight heparins in weight-adjusted doses without the PTT monitoring that is required for heparin. It's also important to note that low molecular weight heparins undergo renal elimination. Dosing of low molecular weight heparins varies with indication. For VTE prophylaxis, we use fixed doses, such as with enoxaparin 30 milligrams sub-Q Q12 or 40 milligrams sub-Q daily. But when we want full therapeutic anticoagulation, we use weight-adjusted doses, and they're listed here on this slide. Now, there are some special populations for which dosing is modified: our obese patients and our patients with renal dysfunction. So in our obese patients, and these are patients with a BMI greater than 30, when we're using therapeutic or full dose anticoagulation, meta-analysis has found that in patients with a BMI greater than 30, there is no increased bleeding, and so we use actual body weight in those patients. However, it's important to note that there were very few patients with a BMI that was greater than 50 in these studies. So for these patients, you might want to monitor anti-factor 10A levels 4 hours after the sub-Q dose. So just to note, by the way, anti-factor 10A levels can be drawn to evaluate for potential toxicity. So if they're elevated out of the normal range for efficacy, a patient can be at risk for bleeds. And you draw them, as I said, 4 hours after the injection. So, in prophylactic dosing of low molecular weight heparins in obese patients, studies have shown that weight-based prophylactic dosing may be preferable in patients with a BMI greater than 30 instead of the fixed doses that we normally use. You can consider a 25 to 50% dose increase in these patients, or a lot of times in practice we'll use a 40 milligram sub-Q BID. Because low molecular weight heparins are renally cleared, factor 10A levels can increase with decreased renal function. So the pharmacokinetics in renal dysfunction differ among the different low molecular weight heparins that are out there, and there's really not one creatinine clearance cutoff value that correlates with increased risk of bleeding for all low molecular weight heparins. So likely a safe threshold is if your patient's creatinine clearance is less than 30, you should decrease the dose. Now I've listed some examples of renal dosing using enoxaparin here. And manufacturers of low molecular weight heparins usually recommend that if a patient has severe renal dysfunction that you avoid low molecular weight heparins entirely and just use unfractionated heparin. But when in doubt, you can always check an anti-factor 10A level. The next agent we'll talk about is fondaparinux, and the brand name is Arixtra. It's used for the prevention and treatment of venous thromboembolism as well as an acute coronary syndrome and AMI. It's a factor 10A inhibitor like low molecular weight heparins. However, it's a synthetic analog of a unique pentasaccharide structure that's found in heparin and low molecular weight heparins that ultimately promotes the inactivation of factor 10A, leading to its anticoagulation effects. Like low molecular weight heparins, fondaparinux is also 100% has 100% bioavailability after sub-Q injection. Its peak anti-factor 10A activity is at about 1 to 3 hours, and it also shows a more predictable dose response than unfractionated heparin. So its excellent bioavailability and lack of variability in the dose means that it also can be used without the PTT monitoring that's required for heparin. So it's also eliminated renally, so we need to keep that in mind for dosing as well. And in contrast to low molecular weight heparin, it has a longer half-life, and it's at about 17 to 21 hours. Therefore, it can be given once daily. When dosing fondaparinux for prophylaxis, we use a fixed dose of 2.5 milligrams sub-Q daily. Our therapeutic dose or full dose, we use weight-adjusted doses. So if a patient is less than 50 kilos, we're using 5 milligrams. If they're 50 to 100 kilos, we're using 7.5 milligrams. If they're greater than 100 kilos, we use 10 milligrams sub-Q daily. Now there's a couple of groups of people for which fondaparinux is not the best choice of agent. It's contraindicated in patients that are less than 50 kilos when it's used for prophylaxis. So there's an increased risk of major bleeding episodes for these patients. It's also contraindicated in all patients when the creatinine clearance is less than 30. So remember, it's renally eliminated, and so this would increase the risk of major bleeding episodes in these patients. Some experts do recommend decreasing the dose by 50% if the creatinine clearance is less than 50 mils per minute. And it should also not be used in pregnant patients due to insufficient data in that population. Moving on to our vitamin K antagonist, it is warfarin. and it is used in the primary and secondary prevention of VTE, for the prevention of thromboembolism and atrial fibrillation and prosthetic heart valves, and other indications in patients with AMI. Now, warfarin inhibits vitamin K dependent clotting factors, which is why we call it a vitamin K antagonist. And those vitamin K dependent clotting factors are 7, 9, 10, and 2. And it essentially knocks them out of the coagulation cascade. Warfarin also inhibits proteins C and S, which are your body's natural anticoagulants, and I'll explain their role further in an upcoming slide. Now, warfarin doesn't directly inhibit the clotting factors. It's a vitamin K antagonist, so in order for those clotting factors to synthesize, they need the active form of vitamin K. This slide is a diagram of the vitamin K cycle. Starting at the bottom of the slide, vitamin K epoxide is the inactive form of vitamin K. Inactive vitamin K transitions to active vitamin K as you go clockwise through the cycle. Vitamin K hydroquinone at the top of the slide is the active form. So this active form of vitamin K is used in the synthesis of clotting factors. On the right-hand side of the slide, you see protein moving to carboxylated protein, and this represents the synthesis of the clotting factors. Active vitamin K is necessary in the process. Warfarin is shown on the left-hand side of the slide, and it interferes not with the synthesis of the clotting factors, but with the vitamin K moving from its inactive to active form. So if there is a reduced amount of active vitamin K available, there is a reduction in the synthesis of vitamin K dependent clotting factors. The clotting factors that are vitamin K dependent are also shown here with boxes around them: 7, 9, 10, and 2. Protein C and S are also inhibited. As I said before, these proteins are your body's natural anticoagulants, and they exert their anti-clotting effect by destroying activated factors 11A, 8A, and 5A to inhibit thrombin formation and thus clot formation. So actually, by inhibiting proteins C and S, you're knocking out your body's own anticoagulation, which is important to understand, and I'll explain why in an upcoming slide. But for the most part, after inhibiting of the clotting factors is balanced with the inhibiting of the proteins C and S, the end result is an overall anticoagulant effect. Warfarin is rapidly absorbed and it has a high bioavailability. Patients rarely have absorption problems with warfarin. Its half-life averages about 36 hours, so once daily dosing is adequate. It's important to note that there is a 1 to 3 day delay between peak drug concentrations in plasma and warfarin's anticoagulant effect. This is because while you have the partially inhibited synthesis of the clotting factors, you also have the unaltered degradation rate of the clotting factors. So you've got these clotting factors that were made prior to the initiation of warfarin that have to go through the normal time it takes for them to degrade, which happens to be a long time. The factor half-lives are 6, 24, 40, and even 60 hours. This graph really demonstrates it best. On the x-axis, you have time in hours, and on the y-axis, you have the concentration of factors in percent of normal. So on the right vertical axis, you have INR. At time 0, warfarin is given, and the squares are the INR as it increases over the first 5 days. The other shapes represent the vitamin K dependent clotting factors. And you can see that they don't fall that quickly. And in fact, the percentage of them that are still around by day 3 is quite a bit. So true prothrombin, or factor 2, represented by the circles, has a half-life of 60 hours, and it takes several days of therapy for its activity to reach the therapeutic range. Now, proteins CNS, on the contrary, which aren't shown in this graph, are actually inhibited much sooner at 8 hours and 30 hours, respectively. And because by inhibiting proteins CNS, you get a procoagulant effect, you have to be careful in those first few days because the procoagulant effect might outweigh the anticoagulant effect until more time passes and a higher concentrations of the clotting factors, specifically 10 and 2, are decreased. So from this we can see that with warfarin, the speed of onset is based on the half-life of the clotting factors and not the size of the dose. Loading doses cannot overcome the long half-lives of the clotting factors. That's why we do not do large loading doses at the beginning of therapy. So it's reasonable to start with 5 milligrams a day for the first 2 to 3 days and then base subsequent dosing on the INR. So an exception is if you're using warfarin in an elderly patient or someone else with known sensitivity to warfarin, you might start at lower doses of 2.5 milligrams. Now, INR target varies per indication. In most cases, a moderately intense target of 2 to 3 is recommended. There are some circumstances that allow for low intensity therapy and high intensity therapy. Genetic environmental factors can play a role in a patient's response to warfarin. There can be gene mutations, and also drugs, diet, and disease state play a role. So for example, warfarin is highly protein bound, about 99% bound to albumin. And warfarin can be displaced by drugs or by any health state that lowers the albumin, such as malnourishment. Also, warfarin is metabolized in the liver, and so patients with liver disease may have varied responses. So the bottom line is that warfarin requires individualized dosing and diligent monitoring. So with warfarin, we monitor an INR. We want to check the INR after the initial 2 to 3 doses. For patients who are on more stable dosing, we can monitor the INR at longer intervals, perhaps every 4 weeks. And then we want to monitor it more often if we're adjusting the dose or if we're adding or discontinuing any medication that might interact with warfarin. As far as dose adjustments, prescribers usually use clinical experiences, formulas, or nomograms to adjust the dose. Most people that use clinical experience make changes of anywhere from 5 to 20% of the total weekly dose to correct moderate INR changes. It's important to remember to make your changes patient-specific. Keep in mind how they tolerated prior changes and even their compliance skills. So will a patient remember to take a different size dose every other day, or will they be more likely to take their doses as directed if you alter their regimen differently? These are some adverse effects to mention with warfarin. Skin necrosis can result from reduced activity of protein C, and it's usually seen in the first few weeks of therapy. Warfarin is in pregnancy is contraindicated because it has demonstrated teratogenic effects to the fetus, and risks clearly outweigh the benefits of therapy, and so it is contraindicated in pregnancy. Now, bleeding is the big adverse effect that we worry about with warfarin. We can give doses of active vitamin K, which will increase the synthesis of the clotting factors to help reverse supratherapeutic INRs. Now, the preferred route is PO. Sub-Q is not recommended because this response is less predictable and it's delayed compared to oral. IV by slow infusion should be used when very rapid reversal is required due to serious bleeding or a major warfarin overdose. We don't want to use it IM. So remember, just stopping the administration of warfarin will also increase the synthesis of the clotting factors as well, because you're letting the vitamin K activate itself again. So giving additional exogenous doses of vitamin K just speeds up the process. But you have to keep in mind that if you want to re-anticoagulate the patient again, or just drop a supratherapeutic INR back into target range by giving exogenous vitamin K, or giving exogenous vitamin K may over-reverse your anticoagulation, and it may take some time to get them back up into target range again, as it did when the patient was initially started on warfarin. There are many, many, many drug interactions with warfarin. Warfarin is metabolized by cytochrome P450. Therefore, there are many interactions with the drugs that affect this cytochrome P450 metabolism system. They can either increase or decrease the warfarin's effect, and it's very important to monitor the INR more frequently when a patient begins or discontinues any medication, including over-the-counter and herbal medications. I've listed here some common offenders that can affect patients' INR through drug-drug interactions with warfarin. I put together a list of some education points for patients when they're first initiating warfarin therapy. So just to highlight a few, they want to make sure that patients take it consistently. So make sure they know that if they miss a dose one day, they don't take 2 pills the next day. This is important with any medications, but it's especially important with warfarin. So patients also don't have to stop eating foods with vitamin K. They just need to be consistent with their diet, so they don't have big fluctuations of exogenous vitamin K coming into their systems, which can affect their INR. So the same with alcohol, they don't have to completely avoid it, just no binge drinking. Also, patients should wear an ID bracelet or carry a medication card in their wallet so healthcare practitioners can see on their see that they're on warfarin in case they're in a situation where the patient can't tell them they are. Also have the patient talk to their pharmacist when they go to their drugstore to pick out over-the-counter medications for aches or pains or colds. Tell them to let the pharmacist know that they're on warfarin and to seek advice on what they choose. Also go over signs and symptoms of bleeding and what to do if they notice any, such as bleeding gums, bright red blood in their stool, nosebleeds, or easy bruising. And then also specifically for your elderly patients, make sure you talk to them and their family members and caretakers about fall precautions. So one last note about warfarin. I just want to let everyone know that there are anticoagulation clinics out there if you didn't know already. They're usually specialized multidisciplinary clinics that are in collaboration agreement with a prescriber. Studies have shown that these clinics can achieve better management than usual care. These clinics can schedule labs, adjust dosing, and provide individualized counseling and patient education. For many years, vitamin K antagonists, or warfarin, was the only long-term option for the management of venous thromboembolism and atrial fibrillation. But now with the availability of direct oral anticoagulants, or DOACs, there are several pharmacologic options to choose from. Now the biggest difference in mechanism of action between warfarin and DOACs is that DOACs target only one clotting factor. All DOACs are used for anticoagulation in VTE and in non-valvular atrial fibrillation.
So some other key things to note when comparing DOACs with warfarin is that DOAC dosing is going to vary with indication, and if a patient has renal dysfunction and other drug-drug interactions from medications that a patient might also be taking in addition to the DOAC. Versus warfarin, which we titrate the dose based on their INR goal to make sure that they stay within that INR goal. Also, DOACs tend to have fewer drug-drug interactions and fewer drug-food interactions. As we discussed, warfarin has a drug-food interaction when there's high vitamin K levels in certain foods, and that we don't need to worry about with DOACs. However, when we do have interactions with DOAC medications, it can be more difficult to manage. And that's because we can't monitor concentrations of DOACs or the effectiveness of DOACs in the same way that we can monitor the effectiveness of warfarin by just drawing that easily accessible INR. With DOACs, we don't measure concentrations, we don't measure any other type of coagulation levels in the patient. So knowing how prevalent that drug interaction is with that DOAC is hard to measure patient by patient. Also, DOACs have a much shorter half-life than warfarin, so there is less time needed between stopping a DOAC and having a surgical or invasive procedure, so that can sometimes be a benefit with DOACs. And also, there are some DOACs that have acute reversal agents available. They can be costly and also have administration constraints as far as mixing them, the time it takes to mix them, and giving them intravenously. And there are more that are under investigation and some that are in clinical trials. With warfarin, we do have vitamin K, which is a low-cost agent, which is easy to administer. We can administer it orally in addition to IV if we need it. The IV is available if we need it to have it take effect with a quicker onset. And then we can also, if indicated, give Kcentra, which is a 4-factor prothrombin complex that's available for patients with severe bleeding due to high levels of warfarin. It is administered IV, but it isn't always necessary to give that Kcentra. And something that is similar between DOACs and warfarin is that they can both increase the risk of bleeding. And it's something that we need to be more cautious of when patients are also on other antiplatelet medications.
So we'll talk about each of the DOACs one by one briefly, starting with dabigatran. Dabigatran is a direct thrombin inhibitor, so it inhibits thrombin, which is factor 2A in the coagulation cascade. It's renally eliminated, so we do need to adjust the dose in renal dysfunction. The normal dose is 150 milligrams twice a day for patients who have creatinine clearance greater than 30 mils per minute. Once you get below that with a creatinine clearance between 15 and 30, they do recommend, if you're using it for atrial fibrillation, to decrease the dose to 75 milligrams twice a day. If you look on the slide with the dosing that is listed for VTE, there is no dosing recommendation for patients who have a creatinine clearance less than or equal to 30 mils per minute, so it's probably best to choose a different agent for those patients. So I just want to talk about drug-drug interactions with dabigatran, and we should discuss P-glycoprotein. Which is indicated on the slide as PGP. So P-glycoprotein is an efflux transporter, which in the gut pumps drugs back into the lumen and decreases their absorption. So dabigatran is a substrate of P-glycoprotein, and so it's important to know that P-glycoprotein inducers can decrease the bioavailability of dabigatran, making it less effective, and P-glycoprotein inhibitors can increase the bioavailability of dabigatran, putting the patient at risk for more toxicities. So many, but not all, of the drugs that are transported by P-glycoprotein are also metabolized by the cytochrome P450-3A4 pathway. Dabigatran is one of those exceptions. Um, it has no CYP involvement in its metabolism. But you do need to note that if given dabigatran with P-glycoprotein inhibitors, there does need to be a dose reduction for atrial fibrillation if you're giving it for VTE along with a P-glycoprotein inhibitor and your patient's creatinine clearance is less than 50, it's recommended you avoid. If the as far as for P-glycoprotein inducers, the recommendations are to avoid if you're using dabigatran with rifampin, which is a P-glycoprotein inducer. Other things to note about dabigatran, the capsule should not be opened, crushed, or chewed. The bioavailability of dabigatran increases by about 75% if the capsule is open and the pellets are taken out of the shell. Also, patients need to know that they should store the capsules in the original blister pack to prevent exposure to moisture. And if they have a bottle, that must be discarded after 4 months of being opened. Dabigatran can be taken with or without food. Rivaroxaban is the next DOAC we'll discuss. It is an oral factor Xa inhibitor. So other medications that we've talked about that inhibit factor Xa, fondaparinux and low molecular weight heparins, those are both injectable products. So this is our oral factor Xa inhibitor. It is also renally eliminated, so we need to adjust the dose in renal dysfunction. There are different doses, again, for atrial fibrillation or for VTE, depending on what you're treating, and then also different cutoffs as far as when you would dose reduce or when you would avoid, depending on your patient's degree of renal dysfunction and their creatinine clearance. This medication, rivaroxaban, is one that is metabolized via the cytochrome P450-3A4 pathway. So the recommendation is that if you are going to give rivaroxaban along with a drug that is a dual P-glycoprotein inhibitor or inducer, and a strong CYP3A4 inhibitor or inducer, that it should just be avoided altogether and a different agent should be selected. With rivaroxaban, it's recommended that patients do take their dose with an evening meal. Apixaban is our next drug. It is also an oral factor Xa inhibitor. It is also renally eliminated. However, it is the least reliant of the DOACs on renal elimination for clearance. So we do need to adjust in renal dysfunction, but only if there are also other risk factors present. So those risk factors, which are listed under the atrial fibrillation indication, is that if the patient has a serum creatinine greater than or equal to 1.5 or age greater than or 80 years old or greater, or weighs less than or equal to 60 kilograms. So if they have 2 or more of those factors, then you dose reduce from the normal 5 milligrams BID to 2.5 milligrams BID. You use a higher dose in patients who have VTE, and there isn't a dose adjustment that's recommended for patients with renal dysfunction. This drug, apixaban, is also metabolized by the cytochrome P450-3A4 pathway, and again, like rivaroxaban, you need to consider the drug-drug interaction if you're giving it with dual P-glycoprotein inhibitors plus strong CYP3A4 inhibitors, either reducing the dose or avoiding it in drugs that have dual P glycoprotein or strong CYP3A4 inducers. This medication can be given with or without food. Edoxaban is our last DOAC. It is also an oral factor Xa inhibitor, renally eliminated, need to adjust in renal dysfunction. Different recommendations based on indication. This one, like dabigatran, has no CYP or cytochrome P450 involvement in its metabolism, but there are some recommendations for either avoidance or dose reduction when used with P glycoprotein inhibitors or inducers. You can also give this medication with or without food. So some general safety monitoring recommendations with DOAC use. Obviously, as I went through each of the drugs, you notice that they all have renal elimination, and so it's important for us to monitor our patients' renal function when they're on these medications. If patients have generally good kidneys, a yearly serum creatinine is usually sufficient. If they're older, if they have drug-drug interactions or fluctuating creatinine clearance or just a baseline decrease in their renal function, you should check their serum creatinine more often. Also, we want to monitor CBC for these patients. Most patients, we can just do this annually. However, in our older patients, patients with low baseline H&H or drug-drug interactions, we need to monitor that CBC more just to make sure that the patients, we don't see any signs of bleeding. So there might be some situations where you might want to use a certain anticoagulant over another anticoagulant based on the patient characteristics or clinical situation. So I'll go through some of those scenarios just to give some guidance on what might be the best choice. So in patients that have an increased risk of GI bleed, apixaban might be a best choice here. Dabigatran has been known to have gastritis side effects or dyspepsia side effects, and the other DOACs that I discussed did have an increase in GI bleed when compared to warfarin. Warfarin is an option, even though it can cause GI bleed, but we think of it as an option just in that we can monitor the INR so we can tell if there is a problem. And it also has an acute reversal agent if the patient is bleeding. So there's a safety measure there. In patients with renal dysfunction, our warfarin, our VKA, again, the INR can be monitored. However, I did discuss how apixaban might be the best choice in these patients as it has the least dependence on renal elimination of all the DOACs. However, it's important to note that in your dialysis patients, you should really use extreme caution because the dosing and the use that we have is really only based on pharmacokinetic data and not actual clinical data in patients. With drug-drug interactions, no real recommendations here, but more just an awareness of, if we have a patient who is on a CYP a medication that is metabolized through the CYP450 pathway, remembering that dabigatran and edoxaban are not metabolized via that pathway. Apixaban and rivaroxaban are both substrates of both CYP3A4 and P glycoprotein, so taking that into consideration. Although there are very many drug-drug interactions with warfarin, a lot of those drug-drug interactions can be managed through INR monitoring when we're doing warfarin, so we can just titrate the dose down and make sure that the INR stays within goal if we need to give the medication with a drug that interacts with it. So in patients that maybe have trouble remembering to take their medications, once daily therapy is usually our best bet. And so we can remember that rivaroxaban and edoxaban are both given once daily versus apixaban or dabigatran, which are both given twice a day. Warfarin is also given once a day, but we do need to take into consideration that we do need patients to follow up with their INR lab draws. So if there is an adherence issue with follow-up, that can become a problem. For patients who are pregnant, low molecular weight heparin is really what the drug of choice is. DOACs are not studied or either not studied or not recommended in patients that are pregnant. And remember that warfarin is teratogenic, so it is contraindicated in pregnancy. As far as cost and coverage, I really think this varies patient to patient. There are a lot more insurance companies that are covering these DOACs. There are some definite advantages to these, although not available generic yet. They're more expensive, but we do need to consider with warfarin. We also have lab draws that need to be covered. So I think really cost and coverage, as far as insurance coverage goes, the right drug really is just dependent on the individual patient.
For the last part of the lecture, I'd like to briefly discuss the guidelines for anticoagulation therapy for patients with AFib. Now, our review comes from the 2019 AHA-ACC HRS focused update of the 2014 guidelines. And AFib is an indication which you might see and use anticoagulants for in your patients. So how do we know an anticoagulant should be initiated to prevent stroke in patients with AFib? Well, the 2014 guidelines as well as the 2019 focused update recommend stratifying AFib patients using the CHADS-2 VASC score. And this is an important tool to know in practice to assess risk of stroke in your patients with AFib. Now the 2019 guideline does, the update does exclude specifically patients with moderate to severe mitral stenosis or mechanical heart valves. Now, these patients have been excluded due to the variability across different cohorts of patients with AFib and their overall stroke rates. So these patients and patients with bioprosthetic valves can be risk stratified using other published methods, and I would refer you to the 2014 guidelines for that. So in the patients that we should be using our CHADS VASC score, we look at characteristics of the patient, which are listed in the column on the left, and then they get a point for any of those characteristics that they have. And then the bottom row indicates how many points they have would equal the risk of stroke they have. So the percent of strokes per year, or their risk of strokes in 1 year. So as you can see, as your CHADS VASC score increases, so does your risk of stroke. So as you can see from this slide, which briefly summarizes the recommendations from the 2019 focused update, that if you're a man who has a 2 or higher CHADS VASC score, or a woman who has a 3 or higher CHADS VASC score, it's recommended that you be started on anticoagulation therapy to prevent stroke. And the options include dabigatran, rivaroxaban, apixaban, edoxaban, or warfarin. So those are available DOACs plus warfarin. However, the new focus guidelines do favor the DOACs over warfarin in those patients who are eligible to receive a DOAC. If you are a man who has a score of 1 or a woman who has a score of 2, anticoagulation therapy may be considered for those patients. If you are a man who has a 0 score or a woman who has a 1 score, it is reasonable to omit anticoagulation therapy in those patients that have AFib. It's important to note that for patients who have renal disease, so moderate to severe, and the guidelines score this by or categorize moderate to severe renal disease based on creatinine clearance. And then or end stage renal disease, either less than 15 mils a minute creatinine clearance or on dialysis. There's some further more specific recommendations. So DOACs can be considered in the patients with moderate to severe renal disease at reduced doses. And then for our patients with end stage renal disease, warfarin can be considered, or apixaban can be considered for oral anticoagulation. However, dabigatran, rivaroxaban, and edoxaban are not recommended for those patients.
Guidelines were published just at the beginning of 2016 for antithrombotic therapy for VTE disease specifically. So these are an update to the 2012 chest guidelines, but it's just regarding 12 topics regarding VTE that were in the chest 2012 guidelines, and then it addresses 3 new topics. So there's a link to these guidelines also in your overview page for and the online readings for this week. So to review with VTE, our acute treatment entails parenteral anticoagulation with either IV unfractionated heparin, low molecular weight heparin, or fondaparinux for the first 5 to 10 days per guidelines. And then you overlap with warfarin therapy until the INR is 2 to 3. Or parenteral anticoagulation can be followed by dabigatran or edoxaban. If you choose to use rivaroxaban or apixaban, you can start those agents without initial parenteral therapy. All DOACs have FDA approval for initial and long-term management of VTE, and DOACs have been compared with low molecular weight heparin and warfarin and found to be non-inferior for rate of recurrent VTE. So that concludes this lecture. Thank you for your attention. I know this was a long lecture. Hopefully you listened to it in chunks. And please post any questions that you have or reach out to your instructor. Thanks.